Hello, everybody, and welcome to the HIV Science MOOC webinar. So thank you for all of those of you who have been steadily following our online course, and thank you especially for those who registered for today's online event. Now, let me introduce myself real quickly. I am Anvita Bhargava, and I have been the community manager of this course. We might have interacted behind the scenes a little bit on the forum, and I hope you have appreciated your experience with this MOOC so far. Briefly, let me redefine the purpose of this webinar, but before doing that, I have the pleasure of having with me today the directors of the HIV Science MOOC. So let me introduce, we have Michaela Müller-Trutwin, who is a professor at the Pasteur Institute, and she's the head of HIV Inflammation and Persistent Unit. Actually, her research over the years has contributed broadly to the discovery of several HIV and SIV viruses and was key for the development of tools that allowed the study of African monkeys as models for protection against AIDS. We also have the pleasure to have with us Asier Sáez-Cirión, who is associate professor also at the Pasteur Institute and the team leader at the HIV Inflammation and Persistent Unit. His research focused mainly in understanding the mechanisms of the control of HIV infection in natural controllers and post-treatment, and also the factors that are associated with the establishment of HIV reservoirs. So both Michaela and Asier today are kindly here to address any questions or curiosities you may have or might have developed during our online course. So for this purpose, I invite you to use the Q&R function that you find amongst the tools in this Zoom panel. And you may at any point type in any question that you may want to ask our speakers. Just to remind you, the purpose of this webinar is scientific. So any question that you may have regarding the course itself in terms of organization, exams, or certifications will be addressed in the forum of the course and not here. So with all that being said, let's, I guess, dive straight into it then. So just a quick intro, because I feel obliged to say this, that we have heard the word pandemic a lot over the last 2 years for good reasons. But all of you know, and I guess that is why you're here following this course, is that we must not forget that another pandemic ravaged the world less than 40 years ago. And this was caused by the human immunodeficiency virus, HIV. 40 years have passed. Many advances have been made, but we are still dealing with it. So it's not a problem solved, let's say. So many of you had the possibility of asking some questions already while you registered to this webinar, and a recurrent one dealt with the topic about HIV vaccine. And it is true that even though there has been vast research, development, and clinical trials, the path has been full of obstacles and challenges. So, to answer this, to address this, I will now give the floor to Michaela, and let's see what she has to say about this. Michaela, go ahead.
Thank you very much. I would like first to welcome everybody together with Asier, and would like really encourage everybody to ask questions. We're here to any kind of question, and we will try to help to answer them as best as possible, or we will try to find information. So again, welcome everybody to this webinar. And I give the floor to Asier.
Yes, so as Michaela said, I just wanted to welcome everyone. We are very happy to see so many of you joining the webinar today. And as Michaela was saying, if there are any pending questions that we cannot address today because too specific or specialized or not clear enough, we will try to address these questions afterward in the forum of the HIV MOOC. And yeah, so I think that Anvita asked about the question regarding HIV vaccination and perspectives, because this was a recurring question. I don't know, Michaela, if you want to start?
Yes, I can start, and we will all then answer together. So yes, of course, the question for the vaccine is one of the big questions. Vaccines are still urgently needed, a vaccine again for HIV, because it will be necessary probably to contribute to help to end the epidemic. We are now close to 40 years of HIV identification, and there's still no vaccine available. There are several reasons for that. I will come to that. In total, in these 39 years, there have been 6 trials of phase 3 for vaccines that have been tested, and none of them worked. Although there have been 400 candidates all over, vaccine candidates in phase 1, but only 6 that were enough promising to go to phase 3, and none of them showed strong protection. Of course, this is very different from the SARS-CoV-2, where within 1 year a vaccine could be found, and there have been about 140 phase 3 trials already done. And so why is it? Why is it that for HIV we still don't have a vaccine? The first trials tried to induce B-cell responses, so antibodies, but none of these antibodies that were induced were sufficiently neutralizing the virus. Then other candidates tried to induce T-cell responses, but they were by their own not capable neither to protect, and the combination of B and T-cell responses using the classical vaccine vectors that we had at the time until now also were not sufficient. What are the difficulties for HIV? The one major difficulty is that HIV is tremendously variable. In my view, there's no other virus that is so variable than HIV. Even as compared to influenza virus, HIV is much more accumulating mutations. I always give the example of the influenza virus, where the variability in the whole world is comparable to the variability of HIV in one single individual. And that's one of the major reasons why it's so difficult to induce protective responses, because the HIV escapes immediately. HIV also takes advantage of replicating in CD4 T cells that are either metabolically very active or proliferating cells, and sometimes the vaccine can even increase this kind of target cells for HIV. In addition, HIV's retrovirus can integrate into the cellular host genome and thus become invisible to the immune system. A breakthrough is probably the discovery of protein neutralizing antibodies that has been discovered about 10 years ago, thanks to new generation sequencing. And these are for the first time antibodies that can neutralize a large variability, a large spectrum of HIV viruses. And this gives a lot of hope. And I might develop this now or later. I don't know, maybe I stop here and I will come back to this point of the protein neutralizing antibodies and current trials and future perspectives later on.
Okay, we will definitely come back to that further on during this webinar. Asier, what is your take on the matter of vaccines and HIV?
Yes, Michaela say, I'm not going to repeat what's already said, that there's many difficulties in terms of the variability and the damage that HIV is going on, the fact that HIV is targeting the immune cells. But some things that we have been doing over the last decades is to gain knowledge about the immune responses that we know that are conferring protection in vivo by studying some particular cases of people controlling infection or resisting infection. And this information has been precious to now go into a new era, I will say, of vaccine development, in which we are aiming at developing exactly this kind of immune responses. So we always aim for the best immune responses, but we didn't have good correlates of protection before. And I believe that we now have a much better defined correlates of protection. And this is, for instance, what is going on with the broadly neutralized antibodies, the new approaches with HIV MRNA vaccines that are in the first stages of testing. And and for which all the knowledge of these last 20, 30 years is being used to develop sequential vaccines that will help to optimize the immune responses against the virus.
All right, this is very interesting. You mentioned the concept of an mRNA vaccine against HIV. Now, this has been something that has been bouncing off of everybody's mouths because of COVID. So Michaela mentioned that one of the biggest challenges of the HIV is its high variability and the rapidity in which it adapts. How would an mRNA vaccine target that?
Okay, yeah, that's an important question. The thing is, I mentioned also the neutralizing antibodies. They have, in the animal model, it has been shown that they really are capable by their own to protect against HIV infection. And so all the mRNA vaccines, I think, that are under development at the moment are based, have the objective to induce protein neutralizing antibodies. And they will do it by two distinct strategies. Either they will, as that was mentioned by Asier, they will try to target germinal center B cells, or B cell precursors, in order which have the initial antibodies that can later on give rise to these protein neutralizing antibodies, which are called BNAbs. I will say BNAbs from now on. BNAbs have gone to many somatical mutations. So that's why you have to go to the precursors and really try to activate those B cells that are capable to produce BNAbs that have this kind of characteristics. Another way to do is to do sequential immunization, like to force the B cells that they mutate. And so you come with the first antigen, and then you come with a second antigen or slightly modified envelope protein, then again an envelope protein, and you force the immune system to adapt. And their models based on the few individuals that had these BNAbs, and these were like simulated and based. So this was the basis of the sequential model. And so the mRNA, they will encode these envelopes that either target the precursors or that model different epitopes. So the concept of the BNAbs is not new. Where the mRNA will help us is to accelerate the process, because producing the glycoproteins is very expensive and laborious, whereas making them produced by mRNA is much more, it's less expensive and it's more quick. So the mRNA will help to accelerate the process and to do more trials in a shorter time for less money. So the concept, it's not necessarily that the mRNA will by itself help us to be more efficient, but it will help us to be quicker. That's my opinion. And even then, although there's a lot of hope now with BNAbs combined with mRNA, there are now several trials in phase 1 to test the safety of these mRNA that encode for envelope of HIV, and also to see if the humans will then produce BNAbs when they are injected with the mRNA. And if this works, it will still take maybe 5 or 10 years until we have the results of phase 3. So we still need to be patient and do a lot of more research on that.
It's essentially making the body do part of the work that would be otherwise very laborious to do in a laboratory setting. So there's some hope in that. I don't know, Asier, if you want to add something, because I know, as Michaela mentioned, there are many clinical trials already ongoing. How promising do you think this actually is?
The short question is, I don't know, and I don't think that nobody knows. What we can say is that there are different trials with innovative approaches, either targeting the antigen presenting cells, so that we are going to address directly the antigens to the cells that are going to present these antigens to the immune effector cells. as described also in the MOOC, there are the mosaic viruses trying to propose different fragments of the virus, of different virus to increase the broadness. There is this approach with the broadly neutralizing antibodies. So hopefully we will see something, as usually happens with this kind of thing, positive response, then will allow us to go further. But we know that yeah, as Michaela said, we have not been very successful in vaccine development for many years. And there may be a reason why, and it's the particular difficulty of intrinsic to HIV infection. So yeah, I'm very curious to see what will happen. Also, what we need to understand is that unfortunately, clinical trials addressing HIV infection are not as fast as what could have been done for SARS-CoV-2 infection, for instance, because the transmission paths are different, the development of symptoms of infection or the acquisition of the virus. There are many differences also in the proportion of people who is going to get exposed, to get infected. So what in the case of some acute respiratory infections could be solved in a few months, in the case of HIV infection, to complete a trial will take years. And this is also a difficulty because to launch in such a long path to a vaccine, yeah, you need to have really clear hints that this may work, or to have solid basic knowledge to go further, because this is will be commit many years into a single trial. So this is another difficulty that we have in the.
Well, so definitely work is going in parallel and has been going on. So let's we can only wait and say. But in any case, so far we still have good news on the one hand, because now AIDS is a very manageable disease, of course, if treatment is provided in the most appropriate way and on time. Now we have multiple questions related to the antiretroviral therapy. As a matter of fact, we have now Samira, who is asking us, what are the reasons that could explain the absence of immune restoration despite an undetectable viral load for several years? And it's true, we had a question also during registration for the webinar. Somebody asked, what happens in immunological non-responders? Why do they not obtain immune reconstitution despite viral load suppression? So what is your take on that? Perhaps we can start with Michaela.
Yes, this is a very interesting question, and it's really of clinical importance. Generally, what is known is that it's really important or better to start antiretroviral treatment as early as possible. While unfortunately most of the individuals who are infected by HIV still initiate treatment in chronic phase of infection. And in France, for example, there's a delay. The delay between the time of infection and time of diagnosis is 3 years. Why I'm mentioning this? It's because probably those where we have more difficulties to totally restore immune responses are generally those that initiated treatment later after infection. The earlier you start the treatment, the better will be your immune restoration in general. And it has been shown that HIV induces a chronic inflammation, and that when you start treatment, you will reduce viral replication and you will reduce inflammation. And again, the earlier you start the treatment, the lower will be the residual inflammation that persists. And it's really important to acknowledge that HIV induces changes in the immune system very early on. It damages the immune system, and that could be the major reason why in some cases it's so difficult to restore CD4 T cells. For example, already in acute infection, there could be cells that they try to control the inflammation, and they produce TGF-beta, which will induce collagen and which induce fibrosis in secondary lymphoid organs. And their hypothesis or data showing that when the lymphoid organs are fibrotic, the cells have, for example, less access to IL-7, and IL-7 is very important for the survival of CD4 T cells. So depending on how much the tissue is already fibrotic, could explain why it's then more difficult to restore normal CD4 T cells. And the other tissue damages that happen early on, for example, at the level of the intestine, the intestinal barrier can be perturbated. It's the residual inflammation also might cause constant migration of the cells from the blood to the tissues. So if there are lower CD4 T cells in the blood, it could also be because they're constantly recruited to the tissues. So these are all the reasons that we think could explain why in some cases the restoration of CD4 T cells is more difficult. There could also be, of course, other reasons that are not well known yet or that I have not mentioned. But all over, there are treatments that try to help the restoration of the immune system, either by, which so far have not given a lot of results, but there are treatments where they try to reverse the fibrotic state of the tissues, or to repair the gut barrier by, for example, by inducing IL-21 or by trying different anti-inflammatory molecules. But the problem is that these treatments are not very specific for the HIV-induced damages, and none of them is very promising so far.
Okay, thank you very much for that response. And that brings me actually to another question that was recently asked about the susceptibility to the antiretroviral therapy, because not all patients respond to antiretroviral therapy. And a user asked, is it important to perform a genotype analysis when it comes down to selecting the right type of antiretroviral therapy? I am not sure if you're talking about the genotype analysis of the viral strain or in the person, because somebody can even be refractory towards certain components of the treatment. How would that complicate matters? Perhaps Michaela, you want to add something to that, and then we will move to Asier.
Maybe I'll let Asier start.
Okay.
Sure, Asier.
So yes, if we are discussing about why people don't respond, and one clear possibility is the circulation and the contamination with viruses containing resistant mutation to antiretroviral molecules, and we know that the number of viruses carrying this kind of mutations is increasing over time. So yes, there are guidelines in many countries indicating that the genotype should be done to best adapt the treatment to the infecting viruses. Then this is not something that can be done everywhere, and this is why there are antiretrovirals, several first, second, third line antiretrovirals that are proposed depending on how people react. And these antiretrovirals are designed, or these lines of antiretrovirals are based on different aspects, including availability, acceptability of for the people, the efficacy of the molecules, but also the circulation of resistant strains to these molecules. So it is important, and it is done, I will say, systematically in countries where this can be done relatively easy. But obviously, this is something that cannot be done all the time.
Okay, thank you very much. I'm going to stop talking about the treatment now and maybe start talking about the PrEP, because there have been many questions concerning the prophylaxis towards HIV. We have somebody asking, is PrEP 100% effective at preventing HIV transmission through sexual intercourse? Or we also have a question currently in the chat asking specifics about the PrEP. How long does it need to take effect? How long this has to be taken after the exposition? Is it after or before? Is the partner of the person in question also protected if the individual is taking PrEP? So if you can address those matters, please.
So yeah, I will start, and if Michaela wants to add something afterwards, and that will be great. So we need to distinguish between what is called pre-exposure prophylaxis and post-exposure prophylaxis. So post-exposure prophylaxis is these are just in both cases these are regular antiretroviral molecules that are used in the treatment of HIV infection, and for post-exposure prophylaxis, this is a molecule that is or this is a treatment that is taken when there has been a risk behavior that has potentially exposed someone to HIV infection. And we know that this post-exposure prophylaxis is effective if taken within 48 hours. I believe that this is currently what is has been shown within 48 hours of the exposure to the virus. We know, in particular, for studies in the animal model, that as soon as 3 days after exposure to the virus, there are viral reservoirs that are persistently established that after the interruption of a post-exposure prophylaxis treatment, the virus is going to come up. And so for the pre-exposure prophylaxis, so this is an alternative treatment that is proposed to people who may engage in risk behavior and that may find other alternatives to protect from exposure difficult to accept for many different reasons. And we can not always say, and I think that as in science, we never talk about 100% efficacy because yeah, this nothing is black and white. But the current data that is available is showing over 90% efficacy of this kind of treatment, and in the cases so far in which the PrEP is not working, is mostly in persons who are not following the recommendations for the taking of the pills as this is supposed to be done.
And Michaela, do you want to add something regarding PrEP and PEP, this matter?
No, I was just going to say what the last thing that Asier already mentioned. It is really important to follow the protocol, that each time, that most of the time when it doesn't work, it's because the protocol has not been followed exactly. And it's the same, if we come back to the resistance to question before, antiretroviral resistance generally increases or appears when the adherence to the treatment is not very strong. So it's really important to adhere totally, because otherwise that's when the drugs are very efficient, but we have to take them properly if you don't want the virus to escape.
Okay, thank you very much. We have another question regarding the treatment. As a matter of fact, combined antiretroviral therapy. The user asks, why is it better to take an approved combination antiretroviral drugs to prevent HIV infection rather than developing one drug that is strong enough to work on its own? So Michaela, you can start.
Yeah, I can start. Maybe two things. One is, as I mentioned, HIV is really very efficient in developing mutations. And what has been shown is that if you have one drug or two drugs, the virus can escape. It's important that the drugs attack different parts of the virus, different types, different level of replication cycle of the virus, because then the virus has to escape to 3 things at the same time, and this he cannot do anymore. That's why it's so important to do the combination of taking drugs that attack the viruses at different angles. On the other hand, what has been developed is at the beginning, like 25 years ago, people had to take 30 pills per day. And today, the 3 drugs can be combined in one pill, in one molecule to take per day. So you even don't necessarily be aware that there are different actions ongoing simultaneously.
Okay, thank you. Asier, do you want to add something to that?
No, I think that Michaela explained it very well, why we need to attack initially the virus at different targets. And perhaps what we can say is that today, what is being explored is simplification protocols for people who had been on therapy for many years, who had been controlled and stably controlled for long periods of time, and with a silent transcriptional activity of the reservoir. So we know that they may have a lower frequency of effective cells, a lower risk of a frequent reactivation of the reservoir. And there are some protocols in which, for some people, well characterized for the moment, there is a simplification reducing either the amount of antiretrovirals in the pills or reducing the number of compounds in the pills, and this is giving excellent results. So perhaps we need to have very potent antiretroviral treatment to initially control the infection. But what is being shown is that probably with these new compounds that are so efficient and with good penetration, this may be well, diminish perhaps after a few years of treatment.
Okay, thank you so much. We have another question in the chat about the interaction between PrEP and I guess also antiretroviral therapy with medication in patients who have other diseases. What is your experience in this, and what is your take in this in case of medical overlap, let's say? Asier, you can.
No, so this is a question more for clinicians, and I guess that it depends on the kind of other medication that is going to be proposed. Like all prevention solutions, not a single one is going to be adapted for everyone. If there is any issue with tolerance or compatibility of one treatment with other, there is other mechanisms of prevention, like the condoms, for instance. And I think that there were also questions about that that we can address afterwards. Even if there may be some molecules that are not adapted or that cannot combine with some other drugs that are used to treat other issues, in general, it's very rare to find someone who cannot receive any antiretroviral molecule due to medical interaction. So there is a lot of knowledge now about different combinations. It may be that in some specific cases, in some specific periods, for people receiving aggressive treatment for other diseases, there may be transient incompatibility, but in most of the cases, there is always a solution for everyone.
Indeed, you mentioned the recent advances in the development of antiretroviral therapy. We indeed have a question regarding that. We have come along so far. So one user asks, can this be justification to declare the end of the condom?
So as I was saying, that is PrEP didn't arrive to stop using condoms. PrEP arrived as an alternative, an alternative for prevention of acquisition to HIV infection. But the condoms are useful for in many different situations. And while PrEP is a specific HIV treatment, condoms prevent from acquisition of other sexual transmitted disease and also can prevent pregnancy. So that there is no a complete. This is not a complete substitution of one or another. All of these tools need to be combined, proposed, and the people needs to know which implies using one or the other.
And indeed, just even if we don't talk about pregnancy and other diseases, as you mentioned, nothing is ever 100% in biology. So additional means of protection are always recommended, even though the viral load may be undetectable. Okay, so
yeah,
sorry, go ahead.
I will address that immediately because this is a question, and I think that this is important. Indeed, even if you, as you say, 100%, we never say 100% in biology. The truth is that if the viral load of someone who's receiving antiretroviral treatment is undetectable, this person cannot transmit the virus. This has been proven in multiple studies now. So there is an initiative that address this question very clearly: is undetectable equal untransmissible. So a person who is receiving antiretroviral treatment and who is well suppressed, the virus is well suppressed, receiving this antiretroviral treatment cannot transmit the virus.
Okay, I think that answers many fears of many people who have been asking this question. Michaela, do you want to add something about antiretroviral therapy and risks during sexual intercourse?
No, I think that was quite complete. I mean, I don't have anything more to add.
Okay, so then we shall move on to further questions. We have Aurélien asking, can we have resistance to antivirals that would be mediated by mobile genetic elements that would be integrated into the viral genome? This is very specific. Another question from the same person is it possible to have interactions between antivirals and antibiotics? For example, synergistic effect or an antagonistic effect? We partially addressed that, the matter of overlapping medications and how different combinations of treatment can be found to be adapted to each person in question. But perhaps if you want to address the first part of the question, one of you can go ahead.
I'm not sure I understand the first question. Can you maybe read again? I don't know, Asier, did you get it?
Asier, otherwise I may invite Aurélien to reformulate the first part of the question, and we will definitely swing back to it if it's not possible to answer it now.
No, I think that he's referring to, I don't know if he's receiving to I guess, to mobile genetic elements that are going to insert randomly into the providers, and then this may provoke the development of new resistance. No, I don't think that that's the case. The resistance that are documented are punctual. Resistance are due to the very highly mutation capacity or the number of mistakes that the reverse transcription provokes during HIV replication. This is what is driving most of this resistance accumulating that can accumulate in the different molecules that are targeted by the antiretrovirals. I hope that that's may answer this question.
Do you want to specifically, comment about interactions with antibiotics in particular?
Not really. Antibiotics don't work to fight or to block the virus. Depends also what we call antibiotics. But what is true is that we are exploring now the impact of the broadness of other molecules that are not direct antiretrovirals that may help, that may have synergistic effects with the antiretrovirals themselves. And this may be because they are targeting specific cell pathways that impairs the replication of the virus in the cells. Yeah, but not antibiotics. themselves.
Okay.
Michaela, if you have anything.
No, thank you.
We have a question regarding coming back to the risks of transmission during sexual intercourse. User asks if showering directly after
okay, we lost Anvita.
Yes,
she's back. You were just away for a few seconds.
Oh, all right. Okay, I'm back now. So I'll just repeat the question. The user is talking about showering after an unprotected sexual intercourse. Would that be enough to reduce the possibility of transmitting the virus? The person is talking about a partner in which the viral load is detected, I guess, is detectable. Okay. So Michaela, perhaps you want to.
I mean, I would say that showering is for sure not enough to get protected against HIV. It's really the method that we already mentioned, like condoms or the PrEP, that can protect, or abstention or circumcision can reduce the risk of infection, but not totally protect. The best protection is really either the condom or the PrEP. And again, there's never 100% protection of it's very important that the viral load is non-detectable in the blood. This gives the best assurance that there's no that the risk of virus transmission is as low as possible. But showering or any other kind of washing is not giving any protection.
Okay, thank you. I guess that sufficiently answers the question. Now I'm going to
perhaps to reinforce that, I even remember there has been some studies showing how even, for instance, acts like vaginal washing may increase the risk of transmission because you may damage the mucosa and increase the risk of HIV acquisition. So.
Yeah, that is actually a very important point to take into consideration. Thank you, Asier.
And maybe something to mention in general is that regarding the PrEP, most studies have been done so far in men, and there will be studies in women, how PrEP protocols are acceptable. And there will also be a development, or is already in development, things like vaginal rings. So where maybe the antiretroviral drugs can be also confer protection. So there might be more tools to come for prevention in the future.
Okay,
but
thank you.
Always based on antiretrovirals.
We have another interesting question regarding the gastrointestinal tract. How can it be an invasion site?
Okay, I can start. So it's very important to acknowledge that the intestinal tract is the biggest lymphoid organ of our tissue. So about 70% of T cells are in the intestine. And as you all know, the CD4 T cells are the major target cells of HIV. And in addition, in the intestine, many of the T cells are constantly activated by the environment, whether it's nutrients or the flora. And so there are a lot of target cells for HIV, and that is why it's the major site of replication in size, in number of cells. Which cells are infected the first is debated. It could be CD4 T cells, like for example, some subsets like as Th17 cells have been shown to be very early on infected in the intestine. It could also be dendritic cells or both. I think it's both that can be infected and then transmit the virus.
Okay, thank you. Asier, do you want to add something on the GI tract?
No, I think that Michaela mentioned the main reasons why this is.
Okay, the same user asks us, we know that the virus can enter through the mucosa, but how is it present in semen? Does semen contain immune cells that it can get infected and then can later infect the mucosa of women? And also, how does womanly secretion contain HIV? Asier, maybe if you want to start on that one.
Yeah, well, do you want to go ahead?
Or Michaela, go ahead.
So the easy answer is yes. I mean, both the vaginal secretion and the sperm include free virions, but also include cells. They include CD4 T cells, macrophages that can be infected. That has been clearly shown. And it has also been shown that infected cells are more efficient in viral transmission than free virions. So, so yes, and that's why then the sperm can transmit the virus. And the sperm can also contain in the vaginal secretion also inflammatory molecules that can eventually help even to the virus to establish an infection.
So again, there's also a matter of viscosity during ovulation. It seems that there is low viscosity during ovulation, but does this act as a barrier or a facilitator of HIV infection? So coming back to the mucosa and secretion aiding the infection, how does ovulation increase the chances?
Perhaps not talking about viscosity or others, but we know that there are, and this is not yet well understood, but there are studies showing how the ovulation cycle may influence or may have an impact in the risk of acquisition of HIV infection. Again, not specifically due to viscosity, but due to changes in hormones and immune responses that occur to allow the fecundation and the implantation of the ovule, of and the establishment of pregnancy. This may increase this may be related to a higher risk of HIV acquisition in women, but I think that this is not well really understood yet. I don't know if Michaela has other.
No.
Okay, thank you so much. Now for the last question from the same person, the person asks a nomenclature question, I guess. So Michaela, you can perhaps address, are quiescent CD4 T cells the same as non-activated cells and the same as resting CD4 T cells?
I will start and Asier will complement. I think it really depends. It could be yes. It could be that they're all this all meets the same, and then it depends in the project which kind of markers are used to characterize. How do you define what is the marker you use to say it's non-activated? Is it because you use, for example, proliferation marker Ki67, and you will compare proliferating and non-proliferating cells? Is it quiescent because you look at the memory state or the DR or other markers? So it really depends. I think they all mean the same, but there are subtle differences that can be very important regarding the infection state of the cell. I don't know, Asier, how you would define it.
No, I think that this may be confusing because of how we address these kind of questions more specifically in scientific papers, in scientific publications. In general, I will say that a non-activated cell is a non-experienced cell, a cell that has not been exposed to antigen stimulation, and quiescent resting cells perhaps is more equivalent in the sense that these are cells that come back after some activation period. They may come back to this status of more resting stage. But there may be subtleties for, as Michaela said, for each scientific publication. So.
Okay, thank you so much. I'm going to take one last question regarding the antiretroviral treatment. User asks, tenofovir and emtricitabine has a half-life of more than 24 hours, but yet we take it every day. So can you comment on that, please? Perhaps, Asier, you can start.
So as I was saying, there are some molecules now, and with new treatment, with new formulations of the treatment, the half-life of some molecules is increasing, and there are new formulations that will allow more space taking of the molecules. There's a number of protocols that are being tested with positive results. So what we know for sure is that we want to have the virus completely suppressed, because if we have incomplete suppression, there may be a higher risk for development of resistance, as was mentioned before. But now, where we are in a situation with multiple antiretroviral molecules, with a longer half-life, with good penetration in tissues, because it's not only the half-life of the molecules in the blood, which is important, is the half-life in the tissues, which is going to be more important, because I think Michaela was mentioning before, the tissues are the larger reservoir for HIV, and this is not yet well understood. What is the half-life of these molecules in the tissues? There is a huge effort today to try to understand how well these molecules penetrate into the tissues, which is the real half-life of these molecules in the tissues, for how long they are going to be effective. And there are, as I was mentioning, clinical trials in which a period of treatment is followed by a period of rest, and there is combinations of different combinations with current regular antiretroviral treatment, and with long-lasting new antiretroviral molecules. So this is something that we will see coming in the next few years. The next stage of antiretroviral treatment, I think, will be personalized treatment, and in some cases this may lead to non-daily treatment.
Okay, thank you so much. Michaela, do you want to comment further, or
no?
We move on. Okay, we have another question in the chat. What do you think of the search for antiretroviral resistant mutation using proviral DNA? What is the importance of this research compared to research on circulating DNA? I am not sure I quite understand the question. Perhaps if either of you.
DNA analysis are always performed on cell associated. So it could be, there is a difference between the proviral DNA and the total DNA, because the total DNA could be linear DNA that is the result of reverse transcription, or circular DNA of non-integrated DNA. But I guess that it may be the question related to that, but in any case, the analyses are performed on DNA that is associated to the cell, no freely circulating.
Yes, and I think the advantage of looking the resistance in the virus in the blood, so meaning on the viral genome, which is in form of RNA, is that this is the replicating virus. Because if you measure the DNA, it could also be the defective virus that anyway does not replicate. Whereas if you look into the RNA, you are sure that you're looking in the virus that is at the moment really productive and the dangerous part of the HIV in the body.
Okay, thank you so much. Which brings me back to frequently asked questions regarding the persistence of HIV DNA, or the existence of other subspecies like the episomal form of the virus. How is this incorporated into the research, and why is this important? Asier, perhaps you would like to address that.
So yeah, it's currently admitted that the most of the persistence is mostly driven by the integrated proviruses. For a long time, so you know, when the viral DNA is produced, there is a part that is going to form episomal forms that are not going to integrate, but can persist. And for some time, these non-integrated forms, first they were thought that they may not contribute to viral replication, and that they might not persist because they are fragile and are going to be diluted with cell division and all degraded over time. And this is true when compared to the provirus. But now, and at least in the laboratory, has been shown that there is some production of some viral proteins that can occur from this episomal form. So we don't know whether this may contribute to pathogenesis. And the half-life of these forms is longer than previously thought of. But when we are talking about people who are on antiretroviral treatment for years, it still seems that the persistent will occur due to the presence of the integrated provirus in the genome of the cell. And this is because once the integrated genome is protected from degradation, and the other is because with cell division, that is the other way the virus is persisting. And this has been shown by showing how the virus undergoes clonal expansion over time, and this is now really shown as one of the major drivers of persistence. This only can occur for the integrated provirus because, as mentioned before, the non-integrated forms are going to dilute with division. So there is multiple studies looking at these episomal forms, but for the moment, nothing has been proven about their implication in the persistent. And why is this important? Obviously, because the persistent virus is what is taking us of the eradication of the virus and the total elimination of the virus. And we need to know where the virus is and which are the forms that contribute to persistence if we want to completely eliminate the virus from the organism.
Okay, thank you so much. Michaela, would you like to add or comment?
That's fine.
Actually, I have a question for you, Michaela, right now, and this is a recurrent question that has shown up also on the course forum. People really are interested in further details. So could you elaborate on the exact transmission of HIV from monkeys and chimpanzees to humans? So I guess it's a general question regarding zoonosis, how and when, what, essentially. Thank you.
Okay, yeah, I can make a summary of what is known. So there are two HIV viruses, HIV-1 and HIV-2. HIV-1 origin is in the Central African region. It's estimated to have emerged in humans between 1880 and 1920. This is estimates on phylogenetic analysis. And HIV-2 emerged in humans in Western Africa later, probably around the 40s, so 1940s, 1945. For HIV-1, there are 4 groups known, M, N, O, and P. So this means there have been four events of transmission from animals to humans. And for HIV-1, we know 9 groups from A to E, meaning that there have been 9 events of transmission from animals to humans. So it's not only one story, it's multiple stories. In Western Africa, all the HIV-2 viruses derive from an SIV that is present in a monkey that is called 𝐏𝐚𝐬𝐿. It's a species that is present in Western Africa. And this is the natural reservoir of HIV-2 viruses. And what is particular for monkeys is that there's little transmission from the virus adults to the infants. So there's high seroprevalence of the virus in the adults, up to 50%, or sometimes 60% of the adult animals can be infected. Sometimes in some colonies, even 80%, whereas the infants are rarely infected. But the infants can be used as pets or taken when, for example, the parents die. Sometimes the babies are taken by the humans and they grow then up with the humans. And it is known that HIV can be transmitted very efficiently through bites. So for HIV-2, what is this under discussion is that it might be that animals that live with humans, sometimes, you know, they can be bitten, and that could be a way of transmission from the SIV to the humans. In Central Africa, the HIV-1 that is the most prevalent in the world is the HIV-1 group M, derives from the chimpanzee virus. So there's an SIV circulating in Central African chimpanzees that gave rise to HIV group M and also group N. And the group O and P viruses are more close to a virus that is present in gorillas in Central Africa. They're not Western African chimpanzee and gorillas, for example, are not infected by SIV. In Central African region, these animals are sometimes hunted. And so the most current hypothesis is that during hunting, there can be easily contact with blood from the animals. And you can, when you cut the animal, or when you kill it, you might get in contact with blood of the animal, and that's the supposed mechanism of transmission from SIV from chimpanzees or gorillas to humans. It's not the meat by himself, because once it's cooked, the virus is dead, but it could have happened through hunting. And then we know that some of the viruses, once they arrived in humans, have been more transmissible, like the HIV-1 group M, it's a champion. And among HIV-2, it's group A and B, which are more transmissible than the other variants. So I hope that answered the question.
Thank you so much. It was very clear. You mentioned the two different viruses, actually HIV-1 and HIV-2, which brings me to another question that was asked. What are the current geographics of HIV-2? Michaela, yes.
Okay. Yeah, so there's no general HIV-2 surveillance existing at the moment. The last numbers that one can find on HIV prevalence date about 2017. So as you all know, there are about 37 million people living with HIV, and among them, it is estimated that maybe 1 to 2 million people live with HIV-2. These are estimates based on previous data that have been obtained in the 90s or around 2000, 2005. The seroprevalence is in some countries between 1% and 4%. So as I mentioned, the HIV-2 is arised in West Africa, and in West Africa, there's still maybe the most HIV-2 circulating in the world. But in many countries of Western Africa, like Nigeria, Ivory Coast, Burkina Faso, that's where the prevalence is. These are the countries where you can find still a lot of HIV-2, which go up to 2 or 4% of seroprevalence. All over, though, the prevalence of HIV-2 is decreasing from the moment on that HIV-1 arrived in these countries. HIV-1 is more transmissible in general than HIV-2. And so you had countries, for example, like the Guinea, where in the 90s you had 8% of HIV-2 and 0.5% of HIV-1. And then 15 years later, you only had 4% of HIV-2, but already 4% of HIV-1. And there are stimulations that say that around 2050, maybe the HIV-2 prevalence will fall down below 0.1%. But again, these are estimates. There's no surveillance system at the moment, no recent data. And dual infections also are generally not really reported. So we don't know whether somebody's dual infected or not. And you can find, well, HIV-2 is more prevalent in Western Africa. You can find HIV-2 in many countries because the virus travel with the humans. You can find HIV-2 in the Americas, in Europe, in Asia, like in Japan or in Brazil, and other parts also of Africa, like Angola or Mozambique. Then it's more a matter of prevalence, but it will be present. It's present in I think nearly everywhere.
Well, thank you so much. Actually, this brings me, it reminds me how important it is to really enforce communication and collaboration between both patients and clinicians. It really quickly, just to approach this topic, do you think it's possible, a user asked previously, do you think it's possible to organize support groups to improve treatment compliance? Another person in the chat asks, what type of collaboration can we see with HIV patients today? Do you think all of these, I know there exist many associations and support groups across the world specific to countries, some of them are even international. Do you think enforcing all of these and really actively participating in all of these can help monitoring and perhaps even treatment scenarios one day? Maybe Asier, you would want to also add something to that matter?
Well, just collaboration with persons or with people living with HIV is ongoing all the time and at different levels. So, and I think that in that sense, the HIV field has been kind of a pioneer in that the patients have been actors of the development of new treatments, new strategies, policies of how to manage infection, access to molecules, many different in many different stages of the development of the strategy against HIV/AIDS. Currently, and to give you some precise examples, we in particular have interactions with community representatives and associations of people living with HIV. They participate in our scientific committees for the development and of research projects, more in particular when there is a clinical translation. They overview the protocols, the clinical studies that we are doing, the documents that are presented to the participants. They overview even how the results are presented to participants, the feedback that we respect in every degree, confidentiality, management of personal data, that we present the data and objectives very clearly. And they also participate more in even in a strategic way. Now that we are developing, or I mean to develop new interventions, aiming HIV cure or remission, or even in the case of vaccines, but perhaps more specifically for new interventions aiming HIV cure or remission. People with HIV are fundamental to help us better understand which are the needs, which is acceptable, which kind of treatment they will be expecting. So the people they are involved since the very beginning in many different protocols. Again, not only in research but also in policy making.
Okay, thank you so much. And I really like the concept of HIV patients being considered as the real actors, and I hope this will only increase further on. So I guess we need to wrap up this session. Actually, this has been quite interesting. Just one last thing to play with the minds. Where are we with the cure? The final answer, and what are the perspectives on this cure? Can we do you think it might be possible to consider a permanent cure now or in the next 10 years or 20, or how would you take this? Michaela, perhaps I would like to have your take on this first.
Okay. I think the interesting point is that there's like a convolution between the research on cure and research on vaccine, and that there's a fertilizing in both areas. There's a lot of development in vaccine research that will be helpful for cure. For example, all the BNAPs that are developed. There's also, but there are of course many other developments that ongoing that either try to really attack the virus directly or to reinforce the immune responses. what is clear is that it seems that it's not the low viral reservoir is not it's necessary, but will not be sufficient to cure, and you will need to induce additional barriers, either to block the virus or to enforce the immune system to really achieve a state of remission. And saying these concepts, maybe I will give the word to Asier, because we already are running over time. So I will leave Asier to finish, to complete.
Yeah, so yeah, I think that we have more and more evidence that HIV cure, I'm not sure, HIV remission for sure may be achievable in the medium term. We have different people who have been able to discontinue antiretroviral treatment and not having a relapse in viral replication, where there are post-treatment controllers, people who receive a stem cell transplant with cells from donors carrying specific mutations. We are now in a process where there are multiple HIV cure strategies in the clinics, and from time to time we see some what we consider for the moment anecdotes of people who keep the viral load under control, but these anecdotal cases keep repeating and accumulating, and I think that this is something that is really positive, because once we know that we can repeat something, recapitulate something, we can aim to increase its occurrence exponentially. So I'm quite positive about the outcome of HIV remission. The problem with HIV cure, complete HIV cure, is that we need to eliminate all the virus from the organism, and we know that the virus is everywhere, and that just a few viruses may be enough to provoke a viral rebound if there are not host mechanisms that avoid this rebound. Also, we don't have currently the tools to prove HIV cure, not even in people who have been allegedly cured. This is more, we talk about cure more often because of the concept of some of the interventions that lead to this status, but we don't have any possibility to prove that the virus is completely eradicated. But for instance, we are monitoring here at Pasteur 30 post-treatment controllers on HIV remission for many years. And in some cases, some of these persons have been maintaining undetectable virus for 20 years, more than 20 years, without antiretroviral treatment, or after interrupting antiretroviral treatment. And they don't have any glimpse of the virus anymore, even if we cannot prove how far is this status from HIV cure, probably not that far. So I think that this may be a suitable outcome, and that may be within our reach.
Thank you so much, Asier, and I thank you both, actually, Michaela and Asier. We have to bring this session to a close now. We're slightly over time, and I apologize for the questions that were left unanswered, but if you could redirect them to the forum of the course, we will do our best to address them in the coming days. So thank you to all the participants and those who interacted. And once again, a huge thank you to both Michaela and Asier and all the organizers behind this webinar.
Thank you, Anvita, and thank you to all the participants and their questions.
Yeah, thank you all. It was great to see such a large international participation.
Very stimulating, yes. Thank you, everybody.
Thank you.